So the title of my talk is Geriatric Trauma, a Different Breed, meaning that they're really the geriatric elder person who is in a trauma victim. They really are a different type of patient than your normal adult trauma or pediatric trauma patients. I am an assistant professor at a medical school in Phoenix, University of Arizona, Phoenix, and I also work as a attending for a emergency department. This is a picture of my parents. 我爸爸和妈妈，我爸已经过世了, but my mom is still alive, living in New York. Now, I live in Arizona, and Arizona is famous for the Grand Canyon, right? Beautiful, beautiful place to go to. I live in Scottsdale, Arizona, and Scottsdale has a lot of mountains and cactus. We're famous for these cacti. You see that? These are called saguaro cactus. They're very special. These are probably 10, 15 feet tall. And they only grow about an inch every year. About 2.5 centimeters every year is all they grow. So these cacti are about 100, 150 years, 200 years old. Now, Arizona is also famous for rattlesnakes. And as an emergency physician, I have to know how to take care of rattlesnake bites. And then scorpions. We're also famous for these scorpions. And we have to take care of them. So I work part-time as an assistant professor, clinical professor at the University of Arizona College of Medicine. At the simulation center, I help with procedures and I work with simulated cases, cardiac arrest, respiratory arrest, intubation, and sepsis, those kind of critical patient simulations. But mostly I am a clinician. I work at this mostly geriatric hospital. It's called Banner Baywood. And there's a total of 68 emergency department beds there. There's 400 or so inpatient beds, roughly 50,000 visits every year. Now the hospital's in a retirement area. So the majority of our patients are older patients. They're geriatric or seniors. And so looking at the statistics, about more than 50% are older than 65 of our patients in the ER. And then only 2.6% of our patients every year are less than 18 years old. So it's very much a geriatric emergency department. And so my clinical experience for 31 years, is mostly taking care of geriatrics. And we have a very high admit rate, 40%, which is quite high. So my goals today for this talk really are the following. I'd like to just give everyone a general view of geriatric trauma and how to think about elder trauma patients. And I'm going to demonstrate or illustrate the concepts of geriatric trauma patient care by looking at 4 of my own cases. These are 4 very common geriatric trauma types. And then through the talk, by the end of the talk, I hope that we can all gain a better appreciation and vigilance towards older geriatric trauma patients, because we have to think about them differently. So what's an older adult? What do you guys think? How old do you have to be an older adult? Well, generally, we think age over 65 is an older adult, okay? But when you think about an older adult, it's not as simple as thinking about somebody who is 40 years old and has become gray, white hair, 白头发, and then they're geriatrics, right? It's not really simple like that. It's not like a fit guy plus gray hair becomes, an old geriatric person. It's just not so simple. Really, older adults, as we get older, everybody understands, we all know this, that as we get older, our physiology changes, and it's more unique, more weak, frail. So we can't think of geriatrics just as a younger person with more years on their calendar, right? So in terms of just broad thinking about older patients, their age is really just a marker of gradual loss of their physiology and their ability to combat trauma. So if you look at this graph from Dr. Shin, she's a geriatrics expert, emergency expert. She has this graph showing kind of the physiologic reserve as we get older, from 20 to 30 to 40, all the way to 80 or so. As we get older, our ability to handle stress gets worse and worse. And so, like, if you're 30 years old, that's the peak. You are at your best at 30 on this chart. So anyway, so just a little bit of statistics. Now, as a side note, most of my statistics are from the US. So we're talking more of US population, patient population. Okay. So then trauma is the 5th leading cause of death in the older patient greater than 65. And even though the elderly, the older than 65 range of patients make up only about 12%, a little bit more than a tenth of all the trauma patients, the older patient accounts for more than a quarter of the deaths from trauma. So you can see how there is such a difference between how trauma affects the younger patient versus the older than 65 patient. So this is a little bit of a busy slide, but essentially what we're looking at is the continuous increase of the population of the older adults, and the more percentage of older adults across the world, we really, as emergency physicians, must be more vigilant, much more mindful of how to take care of geriatric patients. Okay, so this is U.S. Census Bureau data, and if you see on the graph, if you go to 2010, in the U.S., about 40 million older population, 13% of the population. And it is anticipated by 2030, which is not far away. This is 2023 already. It is anticipated by 2030, 20% of the US population will be older than 65. And that's about 70 million older retired people. Now here, this is the latest statistics in the U.S., which is as of 2020, and it's about 17% of the elderly of the population are elderly. Now, I was really curious about the rest of the world, so I took a look at this this graph from the Census Bureau. And the US, there's about 16.8% of older folks, 65 or older in the population. Now, Taiwan, interesting, it's a little bit less, 16%, 15.8% in Taiwan are older than 65. Hong Kong is 18.4, so a little bit more, pardon me. Then South Korea nearby, 16% also. Japan has the highest percentage of older population. So 28.5% of the Japanese population is older than 65 years old. So they have a much older population than we do. The youngest population, the country with the youngest percentage, the lowest percentage of elderly is the New Zealand. They only have their population 15.5% are 65 years or older. So another graph, just quickly go through. Currently in the US, about 13, this is actually 2010, so it's a little bit back. But anyway, at that time, about 13% of the population is older than 65, and the older population consisted of 15% of the emergency department visits. So 13% of the population takes up 15% of the ER visits, and then the ambulance traffic, about a third of the ambulance traffic that comes to the ER is are from elderly. But if you look, the projection in 2030, this is interesting and is important for us to understand the increasing percentage of the population that's going to be elderly. So 20% of the population is expected to be older than 65. That by 2030. This is in the U.S., like I said, and then a quarter of the ER visits, as opposed to previously 15% of the ER visits back in 2010, but in 2030, we're thinking that a quarter of the ER visits are going to be from the older people, and then half of the ambulances that come in will have older people, as opposed to about a third from 2010. A little bit more of statistics for you before you get bored to death, but in the US, you can see, we talked a little bit about it, the 65-year and older population, about 17%, Taiwan, about 18%. So we're very similar, both countries. Now, in terms of trauma admissions, you can see from this graph here that of all the admitted trauma patients from the ER, 70% are female. So so 70% of the trauma admissions are females rather than the males. And then if you look at the most common reason trauma admissions is from falling in the elderly. Okay, so 1/3 of community dwelling elderly, so people who are living at home or with their family or whatnot, 1/3 of those above 65 are going to fall every year. So 1 out of 3, you can think about your uncles and your aunties, your parents, who are living in the community. 1/3 of them will fall every year. Not all of them will get hurt by falling. About 14% will have an injury. If you have grandparents or parents even that are in their 80s, actually 1 out of 2 will fall every year. If you look at the nursing homes, actually 2/3 of nursing home patients or residents will fall every year. Like 2 out of 3 at a nursing home will fall every year. And then 40% of admissions to the nursing homes are because of gait instability and falls. And we understand that sort of in our gut, we understand that. Okay, so we talked about the falling. Now, oops, I went the other way, pardon me. So this is just give you a visual, as you probably understand, as we get older, the mortality gets worse as you go from the 65 up all the way up past 80. And the number one cause of death in the elderly is trauma, really. So this is my mother. 我妈跟我去一个 Royal Caribbean cruise last year. And this is how she walks with her little umbrella she uses as a cane. Why do the senior fall? Why do they fall? I'm sure you know many different reasons. Let's put a little bit of organization and thinking about it. So there's many, many reasons for the elderly to cause them to fall. They have acute disease on top of chronic disease, right? So they have diabetes, they have hypertension, they have cardiac disease, they have neurologic issues. Many seniors have cognitive impairment. Just a little bit of forgetfulness, just a little slight confusion will impact their ability to stay, balanced. Many patients are on lots of medications. I don't know how it is in Taiwan, but in the US, it's very common to have elderly have very long lists of medications, and so polypharmacy is a real true factor in why elderly fall. Sorry, I keep pushing the wrong button. And then when you get older, you just have less mobility and you have less balance, right? You stumble easily, you lose your balance easier as we go older. Now, people who are elderly who have fallen once are more likely to fall again. So if the patient already has had a history of falling, they will fall again. Many will have sensory deficits like diabetes, right? Peripheral neuropathy. They have Parkinson's. They have different issues that give them reduced sensation. And now I'm always surprised that the elderly drink, at fine alcohol level, but it is underappreciated, I think, that the elderly do drink. Postural hypotension can cause falling a lot, and that's because people take medicines like beta blockers, and they take Parkinson's medicines, right? These cause postural or orthostatic hypotension and make it easier for the elderly to fall down. And the elderly do have very often undiagnosed depression that affects their mobility and keeps them very sedentary, and that contributes to their ability to fall or their tendency to fall. So some elderly use assistive devices, like a cane, like my mother has her umbrella and she uses that, but sometimes that gets in the way, believe it or not, and causes falling. Some people use a walker. And then the last thing on this chart, on this slide, is the environmental factor. So more so in Taiwan probably than in the US, but there's multi-generation homes. So the grandparents and the parents, the kids, the grandkids, there's toys on the floor, there's pets running around. So, the elderly just can't navigate through the Legos on the floor, the toys on the floor, the pet is around the corner, running across the room can really contribute to the elderly falling down. So then we talked a little bit about the polypharmacy. These are some of the main medications that will affect the elderly, the hypertensives, the antidepressants, the antipsychotics, benzodiazepines, sedatives, opioids, NSAIDs. You understand that all of these have their side effects that are stronger and more serious in the elderly than someone who is 30 or 40, right? So if you add one more pill, one more medicine above 4, there's a 14% chance of falling, increased 14% chance of falling. So that's a significant risk factor if you're adding on medications. And many elderly are on 6, 7, 8 medications at the same time. Okay, going on to a little bit more of this understanding of trauma and the elderly. So the elderly over 65, 64 that were admitted for trauma, these are the main injuries. Number 1 is a lower extremity fracture. Number 2 is the neck and trunk fractures. And then number 3 is intracranial injuries. So these top 3 are the reasons for trauma admissions in the seniors. Now, I'd like to go through some examples of my own patients, and I think that you might appreciate managing elderly trauma better if you listen to and we talk about an actual case. So I'm going to present 4 cases. These are 4 direct results of falling down in the elderly. Okay, so hip fracture is very common, obviously. Neck trauma, chest trauma, and head trauma. These are 4 very common injuries in the elderly. So this is an X-ray of a patient of mine. I don't know if you can see it clearly. Which hip is the problem? It's actually just the left hip. So if I was in the room with you, I would show you that if you look at where if you're able to see, I know it's hard to see on Zoom, but where the arrow is, there's a very sharp there's a very sharp turn there, and the bones in the hips don't have sharp 90-degree turns there. If you look on the right side, you can see the very smooth surface of the femoral neck. But if you look on the left side, the femoral neck has a 90-degree sharp turn where the red arrow is. So that's where the actual fracture of the left femoral neck. This lady, nice lady, she was just out going to the restaurant with her husband, and all she did was kick the sidewalk. As she was trying to get on the sidewalk, she kicked the sidewalk and fell over onto her left hip. So very, very common hip fractures on the seniors, right? So then just talking a little bit about hip fractures, as you see here, demographics, the mean age of a hip fracture is an 80-year-old. And then most of the hip fractures are females. 80% of hip fractures are females and 20% male. Now, I read that there's a 16% 1-year mortality, which shocked me. I don't know if it surprises you, but it really surprised me to see that in 1 year, 16% of the hip fracture patients will have passed away, have died. So I just always thought hip fractures were pretty easy to take care of and wouldn't have such high mortality. Well, here's a little graphic that shows you a few things. 95% of hip fractures are mostly from a fall, and then 75% by women. This is a slightly different than the other slide. And then on this slide, 20% of hip fractures will die within a year. So similar to what I showed, 16%. This slide is from a law firm actually that collected data. So these are the reasons that lead to the increased mortality of hip fractures. Okay, delirium, pulmonary embolism (EPs), DVTs develop when they're laying down recovering. Pneumonias develop. They get an MI or a post-op MI, post-op CHF. They have urinary retention, and maybe a UTI or sepsis. They have acute kidney injury, either before they fell or due to the procedure or in the hospital. They have anemia significantly if they've lost a lot of blood. And also the decubitus ulceration, right? And that leads to different complications, right? So this is a very simplistic concept to how to really, right from the beginning, be mindful of the mortality the potential mortality for the hip fracture. We want to start right off, making sure they're hydrated well, see if we can prevent any delirium that occurs in the hospital, because that contributes to their mortality. And then a hip fracture patient has to be taken care of by interdisciplinary team. Medicine, has to be surgery, has to be diet, physical therapy, really should be multidisciplinary. And then last but not least is the really good pain management. That's really the humane thing to do. All right, so we've talked about the hip fracture. My patient was pretty simple, straightforward. Neck trauma. Neck trauma, remember, was one of the number 2 reason for trauma admissions in the seniors, right? So this is a patient of mine, 78, just really sharp guy, very lucid. He had a history of diabetes and neuropathy. So he had fallen about an hour and a half before he came to the ER where I was working that day. He said he had tripped and fell and smacked his head against the wall, just really hard. And then when he came in, he complained of really, really bad back pain. Posterior neck pain, and his shoulders were hurting, right? So he's not an anticoagulant. He didn't pass out. There was no syncope. So I look at him, examine him. He's talking to me, but in a lot of pain. You can tell he's grimacing. His eyes are closed. He's sitting up against the back of the gurney, back of the bed. The nurse had put a collar around his neck, okay? And you can tell he was just in so much pain. So I examined him, and I discovered that when I examined his skin, his hands, they were so sensitive. I could barely touch him, and he was in a lot of pain. And that's hyperesthesia, right? more sensation than you would expect from a very light touch. And that always makes me worried about spinal cord injury. So he got a CT head, he got a CT neck non-contrast, and the radiology said there's no abnormalities seen on the CT head and spine. So what do you think? Should I just discharge him home? Put a collar on him, give him some Motrin? Any idea?
Yes, Dr. Lee, I asked a resident to respond to your question. Dr. Lee.
Did they respond?
Young resident. Oh, year 1, young resident.
Oh, wow.
Dr. Lee. Oh, 2, yeah.
So what do you think? Should we send his guy home with a collar?
I think I will consult a neurologist.
Consult neurology, you said?
Yes, did he has limb numbness or muscle weakness?
He does have weak hands.
So no numbness.
It's just very sensitive, very painful, hyperesthesia. So
then I will keep him. I will let him. I will consult the neurologist. So I won't let him go home.
Good. You're a smart one. So I would say no. You never send a patient like this home who has neurologic complaints after falling down. Okay? I always say treat the patient. Don't treat the scan. This is very critical, especially for residents. I've discovered many young residents are very test heavy. So you are learning to make a diagnosis based on testing only. And that's newer. I'm an old doctor. I've been doing this for 31 years and much more old fashioned, and rely on your history and your physical exam. So if your physical examination doesn't make sense with the scan, you need to stop and think, okay, I need to have either more testing or a consultant. So you did right for asking for a consultant. Now, I don't know in your hospital if you can get an MRI, but we can get an emergency MRI, and I did that. And this is what they found.
Dr. Lee, we can arrange an emergency MRI but we encourage our residents to give a reason why, such as a central cord syndrome, something like that. Thank you.
Exactly. Excellent. That's excellent. So I was suspecting the central cord. So that's why I proceeded. In fact, my nurse said to me, the CT scan is back. Can you just send him home? I'm like, no. You treat the patient. You don't treat the CT scan, okay? The patient's got symptoms. He's got neurologic symptoms, hyperesthesia and weakness. So that's all sign of a central cord. So anyway, this is the MRI that I got, and he had a very small hematoma at C5 and 6, right? Your dermatome C5 and 6 is, right? This part 5 and 6, right? If I remember. So the MRI scan corresponds to the physical exam, right? So, and then the MRI reading number 2 was that there was posterior ligamentous injury from C2 all the way through C7. All right, so what do? We don't have neurosurgery in my hospital, so he got sent to a neurosurgical hospital. The neurosurgeon, I looked at his note, and the neurosurgeon described cutting through the dura, and then the hematoma at C5 kind of came out, and he removed the C hematoma, the epidural hematoma that was sitting on C5 and 6. And then he did a laminectomy, and the patient did very well. So neck trauma, we have to be extra careful. This was a ground level fall. Okay, this gentleman, 78-year-old, did not get thrown out of a car. He wasn't riding a motorcycle. He just fell ground level at home, hitting his head and neck against the wall. So we have to be careful, right? So we talked about the hip fractures. We talked about the neck trauma just now. Here's another case I want to talk to you about, chest trauma. Once again, the neck and chest trauma was #2 reason for trauma admissions in the elderly, right? So this is another patient of mine. This guy is very frail. He is 84. He uses a walker. He came in with his son. Small guy and thin. You can tell he's just a frail old gentleman. He had fallen while going to the bathroom, and he had smacked his chest against a toilet. Okay. Just all he did was lose his balance and just strike against the toilet. His son brought him in. This happened about 4 hours before I saw him. So again, we have to really examine the patients well, okay? That's just a very old-fashioned medicine, I guess. When I examine him, I can feel that his chest is really tender. I can barely touch him, very painful, a little bit of crepitus, crunchiness, right? He didn't drink, he didn't pass out. It was just a simple ground level fall against the toilet, against the chest wall. So, you see, I don't know if you can see this x-ray. Do you see any abnormality there? I'll help you. It's not. So you have rib fracture there. You have a rib fracture there, right? On the plain this is a plain rib x-ray series. Am I going to stop there? No. two rib fractures on the plain x-ray. I did a CT scan. He had 6 fractures, 6 rib fractures from falling against the toilet. 5, 6, 7, 8, 9, and 10th ribs were fractured, okay? But not only that, he had flail segments. He had 2 ribs that were fractured in 2 parts of that rib. So these are flail segments. He had a little bit of a pneumothorax on the CAT scan, and he had a contusion of the right lower lobe. So this is a level 1 trauma. This is a guy who has 6 rib fractures and 2 flail segments. We are not level 1, so we sent him to a level 1 trauma center, which is the highest level of trauma care for rib plating, okay? So I guess we're kind of running out of time here, but we'll go through relatively quickly this. When you're thinking about any chest trauma in the elderly, you just have to be really careful and think of them in different buckets. So a child with chest trauma, not too serious. Their ribs are like rubber, so they can, you know, they bounce. Adult with chest trauma, different. They're more, you know, their ribs are more likely to fracture. If you look at older adults, again, even more risk of fracturing. But if you're looking at the very frail elderly, like my gentleman, the 80-year-old who's just really, really frail, you have to really, truly be careful about their workup, you know. Even if it's just rib fractures, the mortality is much higher in the elderly and the elder person, 5 times more high mortality than the younger population. So here's another statistic with each additional rib fracture in the older person, you increase their pneumonia risk by about 27%, and then their mortality goes up by 19%. That's quite a lot by just 1 more rib fracture. So simple graph, as you can see, the red line is the older adult trauma rib patient with pneumonia. It's just a visual for you, and we're already understanding that, I'm sure, that the older individual just have more chance of getting pneumonia the more rib fractures they have. So if you look on the bottom, there's, you know, at 5 to 6 ribs, the percentage of pneumonia is more than 30% in the older and only about 20% in the younger. But if you go over 6 rib fracture, like my patient, 50% of them will have pneumonia. And similarly, the mortality goes sky high if there's more than 6 rib fractures, right? So we just have to be very careful to assess them and make sure to make the diagnosis. All right. Hip fracture we talked about neck trauma, we talked about chest trauma. This is a good one. Head trauma is the third reason that elderly trauma patients are admitted. Another patient of mine, she's 77-year-old, lives alone, independent. She's got hypertension, COPD, chronic AFib, but really lucid lady, independent living lady, okay? She admits she was drinking some alcohol that evening. She said she went to get the mail. She walked out of the house, walked down the driveway, but she fell. She lost her balance and fell and smacked herself right in the face on the ground, okay? So she is taking a Pradaxa. I don't know if Taiwan uses this, the Bigatran. It is a anti-coagulant. In her case, it's being used because of her atrial fib. So I look at her, she's lucid, she's talking like me, clear speech, very with it, calm. Her entire left side of her face was just completely bruised, purple and blue. Her eye was shut because it was purple and swollen. I open up the eyelid and her eyes all injected red. And this is a very important part of your eye orbital exam, is checking for double vision, right? So she had double vision when I had her do her extraoculomotor exam. When I had her look up, she saw double. Okay. Her alcohol was 217. I was so shocked. So I don't know what it is in the Taiwan. In the US, 80 is DUI, driving under the influence. You can get arrested for 80. And this lady had a level of 217, but really talking clearly and did not seem drunk to me at all. So I'm always a bit surprised when the blood alcohol is so high, and the elderly and the senior citizen. All right, so who wants to guess how many injuries we have on this lady in her head on her CT scan? How many? 1, 2, 3 injuries, 4 injuries, 5. Throw a number out. How many injuries does she have? She's on a blood thinner, right? And she smacked her face. All right. She had 6 injuries. 6 injuries. So number 1, she has an orbital floor fracture. So this one arrow on here on this x-ray, there's a fracture in the orbital floor with some 6 millimeter displacement inferiorly. The second injury is the orbital fat is trapped in that orbital fracture, and that's why she had diplopia, right? Third injury, she had frontal subdural, but she hit herself on her face, right? The fourth injury, she had subarachnoid hemorrhage in her brain. The fifth injury, she had multiple intracerebral contusions. So this is a lady who was on Pradaxa, an anticoagulant, much more likely to have intracranial injury. And then the last injury, that is, she had a slight shift from left to right, about 3 millimeter. It didn't affect her mentation, or at least not yet, when I was seeing her. So what happened to her? There is an antidote to Pradaxa called Praxbind. It's specifically and only for Pradaxa, okay? We transfer her to a level 1 trauma center, and she was seen by neurosurgery, ophthalmology, plastic surgery. They all felt she did not need any surgical intervention, and she did very well, is the follow-up I got. So a little bit about head injury in the older adult, okay? Again, just like the chest trauma, you want to think about the elderly as a different bucket, different breed of patients. Start with the child with head injury. There's a nexus. You can look at that for the criteria for who to scan, who not to scan. The child with head injury is not like the adult with head injury. And then the older adult, older senior have slightly different criteria. And the most important adult that you have to be really mindful of scanning is the one who is on an anticoagulant, right? Like this lady. They are just at much more risk of having intracranial injuries. So my recommendation, my advice is just scan all the seniors that have are on anticoagulants. Just a little bit. This was a study from back in 2012, and the patients that were on warfarin tended to bleed less than those patients that were on Plavix. This is another study that was done in Phoenix, actually. And again, just showing you that those on Plavix, clopidogrel, actually had more than 25% of them had some kind of bleeding, intracranial bleeding. And those who were not on any blood thinners at all, hardly had any. Once again, here's another just graphic to say that people on DOACs, which is, Eliquis, Xarelto, Roxaban, these new anticoagulants, they bled less than those who were on Coumadin. Okay, with in terms of head injury and just overall trauma mortality. Okay, quickly, so traumatic brain injury on the 20 to 64-year-old, usually from falling or car accident, right? Falling is 23%, car accidents 23%. But on the patients over the 64, traumatic brain injury occurs because of falling. 75% of the traumatic brain injuries in the elderly is from falling, not from car accidents, not from bike accidents, not from ATV accidents, right? So we just have to be really careful with just a simple ground level fall. So just again, emphasizing, if you're looking at the younger adults that are admitted from the ER, to come to the ER, about a quarter of the younger ones get hospitalized, but 2/3 of the elderly get hospitalized, right? And then the younger trauma patients, out of maybe 5% of them actually die from the trauma, the head injury trauma, not generalized trauma, but a head injury. And then in the seniors, double that, 10% of the older head injury trauma patients actually pass away. So it's quite a difference, double the amount of the younger ones. So this is a difficult challenge. What do we do, right, to keep people from falling? You can't wrap them in bubble wrap. You can't make them use walkers. My mom absolutely refuses to use a walker. So obviously it really requires a team effort from different departments, and let's just go through these really quickly. We talked about acute chronic illnesses, so a good geriatrician and good primary doctor would just be helpful to keep abreast of the patient's condition through the years. For cognitive impairment, if it's possible to get a neuro consult for dementia and medications for that, or psych consult. Polypharmacy, boy, a real problem, unfortunately, in modern medicine. But someone who's an expert at geriatric pharmaceutical or pharmacy, they can help possibly minimize the number of meds a patient has to be on. In terms of the mobility and balance issue, a good neural consult can be helpful. Physical therapy can be helpful. Again, having a history of falling in the past makes you more likely to fall again. And so this is something where the PCP can maybe intervene and keep doing the best they can to keep the patient as healthy as they can. The sensory deficits, maybe an audiologist, if they can't hear, if they can't see, go get glasses or do an ophthalmology consult. Alcohol is a tough one. If you're a lifelong drinker, it's a tough one, but primary doctor can be involved with that and counseling possibly. The postural hypotension issue is medicine related. Dehydration, elderly get dehydrated very quickly, very easily. Medication review, it's helpful to see if they can change medicines, the ones that cause orthostatic hypotension. Depression, counseling and psychiatry referrals are helpful. Assistive device, orthotics sometimes are helpful, special shoes for the diabetic, physical therapy for strengthening the core and strengthening the back. And then sometimes the paramedics actually will tell us how terrible a situation at home is. And we can get maybe some home assessment in terms of getting bars up for the elderly, and then other types of suggestions for a safer home environment. All right. So I hope that today's talk gave everybody an overview of geriatric trauma. I wanted to illustrate the concepts and the statistics with just some real cases, so that will sink into your mind, these stories that'll remind you to be careful about certain types of trauma in elderly. And then I really want the attendings there, and then residents, especially when you're learning about taking care of emergency cases, to be just really paying attention, be more vigilant of the elderly who are trauma patients. A lot of times they're very under triage. A lot of times they're thought to not really have that much injury when they truly have. Like my elderly who hit himself against the toilet and had 6 rib fractures, right? He was put in on as a not a real serious patient by triage until I saw him and worked him up. I just want to give a quick plug. This is a very, very good podcast if you want to take that down, or I'm happy to share my slides with you guys if you're interested. But Dr. Christina Shenvi is the author of this podcast. She's a geriatric CER expert and has really good information on her. You can get it from any podcasting app. So for me, I did have a blog which I stopped in 2021 because of my lung cancer, but it's still there. It's on Emergency Medicine News, and it's called iCubed. And then I'm on Twitter if you want to bother me there or get in touch with me there. It's and then there's Substack. I don't know if you have Substack in Taiwan, but it's another blog where it's my Doctoring, Mothering, and Faith blog. It's much more personal. I will talk more about my faith, my Christian faith, and how that impacts my practice as a physician, and my musings and my thoughts on my own cancer scare. And then if you go on YouTube, this is my YouTube channel. All of my teaching videos are there. If you're interested, there's lots and lots of videos on my YouTube channel, just mostly cases, because I'm very much a clinician and I'm not a true academic. So thank you for having me. And I hope I did teach you, especially the residents, something today.